No, no, you SMS all the practice in private sector. We are joined by our esteemed panelist, Dr. Rakesh Mahajan, who is the president of Delhi Ophthalmology, Tinder Bhalla, who is the treasurer of Delhi Ophthalmological Society, and Professor Ritu Arora, who is the director of the Guru Nanak Eye Center, and she is managing a very difficult position now where GNAC has been converted into a COVID area. So, without much ado, I would request our esteemed speaker, Professor Atul Kumar, to please give his talk on OPD practice and OT. How will it change in government sector? And there can be none other than him who can handle this in the best possible manner. Thank you, sir, for being with us
So,
today and for agreeing to be here on the webinar. Can we share the screen, please?
good afternoon, in fact, early good evening, everybody. And I'm going to talk of OPD and OT practices, in fact, ophthalmic practices in the government setup. Uh, Now, presently, what's going on in the post-COVID era, which is going to arrive soon. And we've actually converted ourselves to an unfortunate pandemic. So we have to gear up for all that, as Professor Namrata Sharma just mentioned. Now, this novel coronavirus disease is called novel because it's a new coronavirus. It has never been before reported before. It's unfortunately, and in the civet cats, probably the ingestion of these wild animals, which takes place in China, has resulted in this. Some say it's because of a leak from a virology lab. Anyway, what you have is a transmission of respiratory secretions, dry cough, sneezing, and you have fever and body weakness, and you get some lung consolidation. The incubation period is about 2 to 14 days, but about 4 or 5 days uh, is is usually the optimum. What to say? By 5 days, you start getting the symptoms. So the asymptomatic period in this 5 days, when the patient may not know anything and you may not anything, the patient is COVID positive. So all flu-like symptoms are there. The severest form is the when you have respiratory distress called ARDS. Now India is fighting COVID, and we aims being part of it we'd like to share it with you. There was an international travel ban by the government of India on 22nd of March, a nationwide lockout from 25th March of 2020. So soon, as soon as we got the information that this is human-to-human transmission, these bans came in. This has helped a big deal. Everybody says that it could have been earlier, but there's nothing which, it's tough to say what could have been, what could have happened, and what could have not happened. Anyway, there's a dedicated website now which is created by the government for COVID, especially MyGov in COVID. So you can know the number of cases. You can also log on to and download an app called the Arogya Setu app, which is a Bridge for Health app. It's a government app. It's a Bluetooth-based COVID-19 tracker. It tells you about the number of the patients who are around you who are also having this app and who may have the disease. It will give you a signal or it will also inform you. It is also a kind of a travel passport. In case you want to even travel to a place like Chennai, you may have to show this at the airport because this will, if it's a green signal, it shows that you're not having COVID or you don't have any of the symptoms of COVID, as well as you're safe. This Arogya Setu app is, as the Prime Minister says, maybe a very useful thing to, you can download this app very easy. So the COVID, actually, if we hadn't government and what we had talked to the government, the aims people really, we really formulated the strategy and advisory for the government. The government went into lockdown. This lockdown really helped. So that 15th April, we would have had, if without lockdown, we would have had 8.24 lakh patients like Italy, who was very close to China and they were making garments and animal skin was being used. So they went into 8.2 plus cases because they never went into lockdown, Italy. Only later they went in. India went into lockdown early, and so we projected figures for 15th April was 17,083. But because of the lockdown, the figures didn't even reach this. We've got registered figures of, we've got registered figures nearly about 18, 19,000 because you crossed 20th April. It's, 15th April is 17,000 when it was 15. It was less than the projected. And now, of course, you've gone to 23rd, 24th, the figures are to 20,000. But still, we are maintaining a very low level. I say flattening of the curve is not yet, but it's a little bit of a flatter side. We're not elevating ourselves too much. The curve is not going up steeply. It's not a steep rise. It's a very shallow upward trend, which hopefully, God willing, and with the people cooperating and the government areas which are there, they will also be, this will go down and so things will improve. I want to just highlight one burning issue for the government because, and for AIMS also, that what is important is that hydroxychloroquine prophylaxis for healthcare workers, the ICMR guideline has come. There is the risk of irreversible maculopathy even at these short high doses for short periods of time. It's unknown, but you will lose vision, which may be permanent. So patients should be informed of the potential for vision loss due to the bullseye maculopathy. The National Task Force for COVID-19, which is ICMR AIMS combined group, says that asymptomatic health carriers, workers and household contacts of lab-confirmed cases are the only ones. That means people who are treating COVID patients or who are household contacts of confirmed cases at home who are on quarantine and isolation. They are the ones who need to take chloroquine. Chloroquine is more toxic. You should take hydroxychloroquine, 4 milligram twice a day on day one, followed by 4 milligram once weekly for 7 weeks. How toxic this is to the macula, we don't know. So there's a lot of work and a lot of senior ophthalmologists, senior epidemiologists from the US who strongly said against using this dose until it is confirmed that it is safe. So I just want to tell you the next important point which the government feels and the government viewpoint is the N95 versus respirator versus the medical and the cloth mask. So as the N95 mask, it's actually called a respirator. The personal caring for COVID-19 wards, ICUs, isolation wards, where the COVID-19 patients are admitted, and aerosol generating procedures, because this virus is an RNA particle which is in an aerosol form. The aerosol is when somebody sneezes, a droplet falls down, but the aerosol is smaller than the droplet. So the mucus evaporates and only the virus is floating in the air for 3 to 4 hours. And it will be sitting on a flat surface. So they say that N95 masks are only for those who are maybe in ophthalmic, seeing from the ophthalmic viewpoint, feel from the OPD patients who come to you directly, and you have no idea of whether they've not got their COVID testing done. You feel, maybe they can wear the N95 mask for the people who are seeing patients in the OPD. And medical masks and surgical cloth masks are for everyday use. If you're not seeing patients in the hospital, then other staff can wear the medical mask. The OT also, we feel there's a slide ahead that we feel the medical mask or the 95, because OT is a very sterile area. We already have patient wearing a mask. We already have extra drapes over the patient. Patient wears a mask. You're wearing a, a medical three-ply surgical mask. A medical mask can be the three-ply surgical mask to keep it from the side. So then it will suffice. So N95 is directly when you're seeing the patient in the emergency or in the OPD, probably that is good enough. So in the AIIMS, we've come up with this standard operating procedure that you have five will be given to you. You wear day one the first mask. The fifth is reserved. The 4 masks are there. Day one wear the first mask. After day one, put it in a brown bag, let it dry near the sunlight. And day two, mask 2, you go for duty, return home, put it in the bag. Same thing 3 and 4. Use the day one mask on the 5th day again. So if you circulating it this way, you can use it for about total 20 days. So they were found that according to CDC and all, what aims is the devices that this works very well. So you don't need to throw away these masks. These masks are in short supply, and because they're in short supply, N95 shouldn't be used once and thrown. You can use it again, and even for 4 times you can use it. The respirator works very well. You just have to be careful you don't stay inside. If you care for your mask, the mask will care for you. And this donning and doffing, we have stressed a lot names, and we feel that you should wear the clothes when you're going into an area which is COVID positive. Please wear your clothes, your overalls very carefully. This holds true for ophthalmology also. We have to be extra careful when we wear our clothes, and put the mask. This is a three-ply surgical mask, and make sure the mask is totally airtight. You make sure that there is a little metal grip which can hold it, as well as a tip. So if you want, you can put a face shield over it, and the glove should be well covered over the overall, which we usually do. So not much change in the OT setup. Now in the casualty in the OPD, I feel all these things which you already know, but the system should have a white glass plastic screen between the patient and your eyepiece, or you can have, as we do in RP Center, we have this X-ray plate, very economical, and we've got these plastic shields made for plastic shields made for a casualty 24/7 casualty residents there. We make this casualty, we make these shields upstairs in the ocular pharmacology lab. It's literally a factory running there now, and we create these polyester film. We have polyester films, and this is stretchable elastic polyurethane, which is available very freely and very reasonable. With a fastener at the Velcro fastener at the back. So this polyurethane uh, thin band is attached to this polyester film, and then the person can wear it, and you can wear it and you can clean it afterwards, or you can throw it away, because these are coming in plenty. And if you just clean it, you just clean it with little sterilium, with any alcohol based wipe. So this is a useful thing, and in our 24/7 casualty, we are encouraging physical distancing. We have 3 sit lamps, so we make sure the sit lamps are at distance. So of course, all these things are already there. So this is a very interesting video which I like to hear. Hardly a minute.
Can the audio be increased?
Yeah, sure. Audio. Okay, so in the Indian scenario, one thing very interesting in this slide, which I'm trying to highlight, is that we are mostly asymptomatic. So we are creating a lot of panic, as I see on most of the groups, the elite group and other groups, which are the good groups, that people are worried about what's going to happen to them. Now, the thing is, most of us are asymptomatic. Now, why is this so? Because we have a number of infectious diseases, including tuberculosis, maybe. We received the BCG vaccination. We have had malaria at some time when the infectious diseases, malaria also. We have some kind of genetic resistance, probably to ACE with maybe ACE2 variant, so that this RNA virus or single-stranded RNA virus attaches to the ACE receptors. So it cannot attach because there is some variant of the ACE enzyme in our bodies. High temperature and humidity in India may also play a role. May. So what I'm saying is the asymptomatic people are good to have because they are not to worry. They are actually going to contribute to the herd immunity. When 60% of the Indian population gets uh, COVID exposure, it will become a herd immunity, and and the disease will die down. This is the natural dying down. And of course, the other dying down is when you take a vaccine, which should be available next year. We're coming to this post-COVID area as the curve is going downwards. We are not getting cases. We are getting cases, but most are asymptomatic. So the number is not so important. The deaths are much more important. The deaths are not very few. In fact, Delhi had no deaths for the last 3-4 days. Acha, besides in the center, we are preparing the patient for the hospital for COVID. We will be not going to use central air conditioning in our OPD, which we have. We're going to open doors, use the window AC, which we have much. We'll improve the ventilation. We'll keep the door of the OPD open. And so no cooling, which will transmit the virus, and no internal recirculation of air via centralized air. Use an adequate number of hand wash, sanitizers, PPEs. We'll use a 95 probably in the OPD because we are directly exposed to the patient, and we'll use sterilium. And of course, the patient will be brought in one at a time. There'll be physical distancing, the physical distancing, and we will follow the AIMS guidelines for recycling of reusing the gloves, the masks. We use disinfection of surfaces with appropriate 2-hourly Bacillol. Bacillol works very well. It's alcohol based. It's freely available as Bacillocid. So we'll fumigate all the area of the OPD with the Bacillocid every 2 hourly, and at the end of the lift stairs, we're avoiding overcrowding. We put these markers on the lift, and we are also just writing about social distancing or physical. And hospital attendants, of course, active education. We are taking classes. The nurses are taking classes and counseling OPD patients because being a larger hospital, our patients many times come from a middle or lower middle class or a lower class setup. They require some degree of counseling, and biomedical waste is really keeping off. So physical distancing, we are keeping the alternate chairs. This can work. In the emergency and urgent care priority, we are using this badge principle. The COVID questionnaire, they'll be asked, and they'll be asked for any history of respiratory or travel. Uh, Special attention to high risk population. Ensure only one attendant. Ensure face mask and hand hygiene. The doctor being put it. And if we're not going to keep body temperature checking, but we're going to make sure the history is well taken. And the person at the gate also has his hands. The patient also has his hands disinfected. Patient would be sitting, as I told you, seat apart, and of course we're going to strictly go by appointment, and we'll stagger the patient. We'll call them between 8 to 10 to 12 to 2. So we'll have to increase our OPD timing. So all few patients between 8 to 10, and after they've been seeing, then 10 to 12 batch comes, and 12 to 2. So this way we'll minimize the waiting time also, and also see the patients without having too much crowd. While examining patients, I've already told you that the triple layer or the N95 can be used, and goggles, face shields, gloves, body protection, and full suit only to be worn. Full suit, PPE suit, IVAC suit should be only worn in a COVID ICU or COVID isolation area. This is a minor OT. I took pictures yesterday. This is when we give intravitreal injections. We wear the N95 mask, and this is a patient also who's lying for the intravitreal injection is wearing the mask. So we have fully protected ourselves, and of course the routine OT gown and the cap we are wearing. So many things will remain the same. Very few things will change. Maybe the N95 is a addition. Planning surgery, you have to do a patient stratification based on risk assessment and severity. Again, using the triage principle. Take all consent. You're preparing a self-declaration form, and with proper consent that he be knowing that there are risks of getting COVID even after the disease, after the surgery, or he may be having it. So all those things are told in the consent form. We've already preparing it. By tomorrow our consent for self-declaration form and a revised consent form will be ready. We're preparing SOPs for OPD, OT, teaching, academics, and for wards, and for our community ophthalmology services. So we're preparing a SOP for everything, and we'll strictly follow the SOP so that we can follow a particular system. And if any patient is serious, feels or we feel that he's got some COVID-like disease, which we shouldn't get paranoid about, actually speaking, and we want to send him to the screening OPD. We have D5, D6 in AIMS, and we have the trauma center in AIMS has been converted to a COVID hospital. And this is sepsis in the OT. We have HEPA filters. We'll maintain the ventilation 18 degrees, 24 degrees, humidity 50, 55, 25 air changes an hour. Disinfection of every area of every case with Bacillol. Sterilization of equipment. We have the flash autoclave and plasma sterilizers. And fake tips after each surgery, we're going to make sure they get autoclaved. So these are the various agents. We already know if sodium hypochlorite is the bleach is very, very potent, alcohol based. The hydrogen peroxide, which we use, is also very effective, and we use it for fogging at RP center, and of course, povidone iodine for painting the eye and all that. So this is the GA. The anesthetist role is very important because he's going to intubate. So he's exposed to the respiratory tract. So we have made sure the anesthetist since last week have now started wearing those gloves. All they're wearing, but the full OT gown properly worn, and he's got a surgical mask and he's got a face shield. Any respiratory secretions, if your patient coughs, he should not come out his face, so he's making sure he's wearing the face shield in the RP center GOT. And for surgeon, day surgery should be preferred. Use the standard PPE with option of three-ply. This is the only thing you can use a three-ply or a routine or the 995 in the OT for the surgery, non-COVID patients. Only if he's COVID positive, we'll have to use a face shield and gloves and all that, and it's like a patient of HIV will treat him. Otherwise, additionally, I feel the OT PPE would be the same. The patient will wear a mask. You can shift from an N95 to a 3-ply mask versus yours. And if he's a non-COVID patient, 3-ply mask should be enough. And only essential patient staff should be there. Avoid overcrowding, 20-minute gap between surgeries, which we usually have. So OT regimen will essentially remain unchanged, I feel. This is just surgery done yesterday. So the advantage of a 3D surgery is that you can see the amount of distance we have from the patient. The patient is here, we've got at least 2 feet distance. We've got a 3-ply mask here, which is taped from above. We've got goggles here, and the patient is under 3 or 4 gowns, and then there's a offside, and he's wearing a mask. So what I'm trying to say is that enough precautions we don't need to change. Teaching activities will be very important. We shift to virtual classes, and that's a thing because many of us are used to classroom activities. So surgical class, we'll have to have teaching classes, virtual classes, and video-based demonstrations. We can have webinars, surgeonars, and of course, residents and fellows will be advised to learn from online material, e-journals. There in plenty. Now, NIH has begun clinical trial of a vaccine which since March 2020, and they're very hopeful by the end of the year they'll have it. So, one thing is keep some staff and residents as a reserve, because if somebody gets infected, all his close contacts will have to be sent to quarantine for 15 days. So, reserve staff should be there, roster-based rotation of residents or staff to minimize COVID exposure. Any vulnerability in a system should be shut down. Leave provision with patients, people with URTI or who are testing positive should be sent home when they have a suspected symptoms also. And follow the government guidelines. Encourage health insurance for all the workers and the doctors for documentation of, like I said, the self-declaration form and the consent form can be one, merged into one, but it's important to keep that signed by the patient and his relatives so as to avoid legal liabilities. And I'm just finishing. Possible challenges in the government setup would be limitation of funds, which are not going to be so much of a problem. And the limited supply of PPE also, at times we don't foresee this problem. And but this is a problem which will be there. And this is the last slide, which tells you that we are now using teleophthalmology at AIIMS in a big way. We've been given these devices which are 4G enabled, and so we are calling up patients who are scheduling their appointments. We ask them if their problem is serious. If it's serious and it sounds serious, then we ask them to come to the hospital. If it's mild, then we just put the treatment on phone. So I think teleophthalmology will play a big role in reducing the patients coming to the hospital, and I'm sure in the private sector they can be charged for this fully. And why shouldn't they be charged? There's every reason to be charged. Thank you so much.
Very nice take, sir.
Thank you, sir. I think that was a very complete and a comprehensive presentation, and so many
Thank you.
questions which we have been having in all the COVID webinars have been by and large answered. And thank you for that great and excellent
Thank
presentation.
you.
It is my pleasure to now invite Dr. A.K. Grover, who would be talking to us about changes in OPD practice in the private sector. And we have a lot of questions which are there on the Facebook, because we are Facebook Live and YouTube Live as well. And we'll be taking them in the end after the presentations. Dr. A.K. Grover, sir.
Thank you,
I think
Dr.
again he
Rakesh.
needs no introduction completely. Everybody knows him.
Thank you, Dr. Rakesh, Dr. Namrata, Dr. Balla, for this opportunity to be with all of you in this wonderful Delhi Ophthalmological Society Symposium. Thanks to Professor Atul for having given us a beautiful perspective of the disease as it exists in the world today, its perspectives over the next few years, like few months, how it is going to settle down or increase, and having given us a very good overview of how things should be tackled in a government setup. I'm going to switch over to how to do this in a private setup and what change in perspective takes place when you are with a private setup or when you're managing a center of your own. So let's look at that perspective now. So let's talk about OPD practice in the times of COVID or the post-COVID era, with the transition as it is likely for the private sector. This is the mandate that I have from the Delhi Ophthalmic Society. Well, the first question to look at is, how long is the COVID era going to last? Now, there are as many opinions as there are epidemiologists, but we can say for sure at this stage that this is not a disease which is going to go away in 2 months or 3 months. We're probably going to live in the COVID era for a fairly long period of time, possibly a year. So when we talk about a private practice, what economic consequences will it have on an ophthalmic practice will largely determine how you carry out your things in the practice model. The very first question is that your survival itself becomes at stake for many practices because of the economics involved. And you need to achieve those scales of economy which gives you that reasonable profitability to survive. And how this will pan out, how things will go, will very much depend on how long this crisis lasts, how well it is controlled, and how it allows us during the intervening period to survive with our financial resources and reserves, with the cash flow at a huge risk of drying up to virtually zero as it is at this moment. So achieving this right scale of economy will require a huge balancing act. The inputs have virtually dried out. We will need to look at the possible volumes and numbers in the future. These will also need to be limited because of the constraints of the infection prevention. And we also need to look at the costs. We need to curtail the costs, make sure that we supplement our inputs from as many sources as we can. So let's look at first the practicing in the COVID era, which is going to be with us for a foreseeable future. We'll talk about the era of the lockdown and possibly the post-lockdown era, which may start for us rather soon than late. We, of course, will have a talk on surgical practice by Dr. Bharti. I will be talking about the outpatient practice in a private setup. First of all, we need to know that we are governed by the Government of India regulations for the workplace, which talk about adequate arrangement for temperature screening and sanitizers, social distancing norms, gap to ensure that sanitization is done adequately, Arogya Setu app to be encouraged. Those above 65 or parents of those under 5 may work from home, and sanitization of the workplace with avoidance of large meetings. So these are the lockdown 2 guidelines from the Government of India. Now we are further helped by the excellent work by the All India Ophthalmological Society through their various webinars, and this May issue of Indian Journal, which came out yesterday, gives us some more guidelines, and we look at those guidelines which are pertinent to an ophthalmology practice. So let's first look at the triage that has been given to us after this particular publication came out. A patient that comes to an ophthalmology clinic, the first thing is to screen for fever. Those with fever will only be tackled if they have emergencies. Otherwise, they're referred first for medical care. If the patient is to be tackled because of an ocular emergency, it must be done in a designated ophthalmological setup, which has all the personal and general protective protocols and protective dresses. And this needs to be done in a designated isolated clinic. If there is no fever, then you have the history of travel, occupation, contact, and clustering. Now, this history is very important. This history will tell you whether you can go ahead with the further examination of the patient, or you need to send him directly to another clinic where there are designated areas for tackling the COVID positive cases. You also look at the symptoms of upper respiratory infection and look at whether the patient has an acute conjunctivitis, which, as we know, can be a manifestation of COVID. In all these circumstances, any of these being positive, the patient goes to a designated ophthalmic facility. If all these are negative, which we will determine in the area before the patient enters the main clinic, then you see the patient in a regular ophthalmology clinic with all the precautions which we will talk about. Now, there are guidelines for hospital staff. Now, these have been developed from the Ministry of Health and Welfare guidelines. There are guidelines for the area of entry and screening. There are guidelines for the waiting area, guidelines for the sanitary staff, administrative staff, and for those who look at the patients. Now, we will look at these in detail as we go to the patient OPD flow. Now, what are the international recommendations or international practices in vogue at different places for protective measures. These have been divided into those for ophthalmologists and those for the patients. Let's see, for the ophthalmologist, face mask is a routine followed in all countries. Now, you can talk about when an N95 mask is important, and we'll talk about it when we go further. All those procedures which are aerosol producing, the N95 mask would become essential, and all those situations where you handle the eye and you may be exposing yourself to the secretions from the conjunctival sac, it would be preferable to have an N95 mask. So this is a precaution which all centers are taking. Gloves are being used in Italy and in China, but many of the other things like goggles, cap, and gown are not a universal practice. A slit lamp biomicroscopic shield is something that all agree upon. For the patient, it is vital to have temperature screening. A face mask is important, and single accompanying person, reduction of non-urgent encounters. All these are important, and patient must be screened with all those questionnaires that we spoke about, and we'll talk about that in detail. Now let's look at some of the general protocols that need to be followed in an eye center before we go to specific patient flow. A daily fogging of the center or clinic is important. A regular mopping of floor and all surfaces at least 3 times a day. Mopping of all railing, switches, handles every 2 hours. Cleaning of washrooms every hour, as is normally the practice, even otherwise. And proper waste disposal with color coding. So cleaning with disinfectant, at least 2 attendants need to be circulating all the time to look after the general areas and the outpatient areas. Waste disposal with all designated protocols in closed baskets, closed dustbins is important. The use of bacillocid hypochlorite or an equivalent solution is vital. You must know how to reconstitute it and use it adequately, both for surface disinfection as well as for fumigation. The other important measures in sanitation are an open door policy. You avoid touching handles. A good ventilation is critical, as central air conditioning is to be avoided unless with HEPA filters. And you need to have hand sanitizers available everywhere. So this is the kind of OPD we keep. We have open door, open window, and the entrance to the reception is also kept open so that the handles are not touched. The next set of general measures pertain to personnel. We'll be talking about their individual protective equipment later, but first and foremost is educate them thoroughly. We have held several sessions with them, and we will continue to do that. You need to have the information and protocols displayed everywhere. The essential staff alone is to be called. You have a roster where you will have at least half the people in reserve, at least at this stage when the numbers are limited. We are avoiding the use of finger attendance. We are not using any white coats or long sleeve shirts which can get contaminated, which is also true for cell phones in the OPD. And lift is used only for patients, and extreme care is taken to take care of all the knobs and sterilize them well. The protocols have been displayed at several places, both for the staff and for the patient that walks in. Now let's look at the patient flow. The patient flow begins with the appointments, the entrance and screening, the front desk, the optometrist's workup, the doctor's chamber, and finally the pharmacy and the opticals before the patient leaves. Now, when the front desk receives a telephone call. He does exclude any exposure or COVID disease suggestive history. He also checks whether the consultation is an emergency at this time, which may not be the protocol once lockdown is opened. He has to make sure that the appointments for an individual are given at every 15 minutes. This is not just to prevent overcrowding, but also to ensure, as you will see, the cleaning of the chamber and all surfaces before the next patient steps in. There has to be enough information to the patient regarding wearing of mask. They have to be told about coming punctually, and they have to be told that they have to have no or only one attendant. And they are given a payment link so that wherever possible, a cash handling is avoided. Now, when the patient appears at the gate, the guard at the gate, which is only a single entry gate, has an appointment list and shows that the entry is with appointments, prevents entry of non-essential persons like those without appointment or like those like medical representatives who've not come with any prior appointment. And he also briefly asks them that they have no respiratory infection before he directs them to the screening area. And there are those marks which direct them to the screening area where they go first, which is in the ground floor before the area of the reception, on the floor below the floor of the reception, where we have staff who has all the protective gear, mask, face shield, gown, and gloves. He does the thermal screening for everyone. He gets the patient to fill with his own pen the COVID screening and consent forms, which are placed in the basket without him touching it. He ensures that everybody, including the attendants, are wearing masks. And then they are directed to the hand washing area within the screening area, where all those who can will wash their hands, other will receive the sanitizing solution. He makes sure that the social distancing is maintained, and he familiarizes them with the further protocol. So this is the patient screening area, which we have in our cafeteria now. The cafeteria is closed. He does a thermal screening, and then he directs the patient to the front desk. In the front desk, patient is well protected, and patient leaves his registration form in the basket here. He has already given his consent form and questionnaire downstairs. Then complete data of all visitors is maintained, which is a regulatory necessity. He is asked about Arogya Setu app. At present, this is not essential, but he is asking everybody for Arogya Setu. He maintains a social distancing, minimizes cash dealing, trying to do it by the digital method, and you have a very well spaced out reception area. So this is the reception, and the person, the receptionist, is well protected. He maintains a good social distance. The chairs, the central chairs are marked as non-seating, as Dr. Atul had pointed out, so that there is no crowding and the patients are really far from each other, well spaced out. This is also ensured by the guard that he does not allow more than 4 patients or their attendants to be inside naked at any time. The others will wait in their cars. The optometrist needs a greater protection, especially if he's going to do the any aerosol producing procedure. He has mask, gloves, and face shield, and this mask will be N95 if he's going to do any procedure, where a contact procedure or an aerosol procedure. They change gloves after, these are examining gloves, they change gloves after every patient. They try and take visual acuity with disposable cardboard pinholes, and they would use refraction only when necessary. No non-contact tonometry is done, as it is known to produce aerosols. And if a refraction is done, then frames are cleaned after every patient, and all surfaces are cleaned after every patient. So this is the chamber. There are 3 chambers, so only 2 are in use at one time. The 3rd chamber will remain free. That will be used till the next chamber is clean. and they are well protected. They avoid the use of NCT, contact procedures like A-scan, applanation tonometry as well. They prefer non-contact, non-aerosol devices like IOLmaster, AutoRef-K. In the doctor's chamber, again, protection is important, including face shield and goggles. Examination gloves. They change gloves after every patient. There is a slit lamp protection guard. There is no talking when the patient is on slit lamp, not until the patient is at least 1 meter away, and that too a very minimal talking at this stage. Slit lamp examination, 90D examination are not done as a routine, but only where necessary. They do need to be done quite frequently, and therefore eyelid retraction is done with swab sticks. The reports of the patient are seen with the patient holding them in his own hands rather than exchanging it. So we have these outpatient chambers. 2 chambers are generally available for a surgeon, and he can shift from one to the other while the cleaning of the chamber goes on. And we would have these sanitizing solutions to do that. The shields are also cleaned after every case, which are in use and on the slit lamps. And the patients are examined with all these precautions. The procedures like fundus photography and OCT are performed wherever necessary, but fundus fluorescein angiography is being totally avoided at this moment. Humphrey visual fields only for very limited cases, and B-scan again for limited cases because there is contact involved. Lasers, both the double frequency and the YAG, are being only used with very, very limited possibility. Finally, when the patient has been seen and he has his prescription is available to him from the opticals for those who opt for a printed prescription. For others, it may be sent by an email. In the pharmacy and optical area, again, a social distancing is maintained and maximum possible effort is made for it to be paperless. At present, the optical area is not functioning because we are seeing only very limited number of patients. But when we use it, there has to be all items handled by the patients in the optical area. And the mask and gloves are important in the pharmacy area. So this is the pharmacy area and the optical area. We've spoken about the difficulties involved in financial dealings, financial ensuring of appropriate scales to run things well, and the difficulties involved, the number of patients that can be seen. These are troubling times for all private practitioners, those who have invested a lot, those who have huge installments to go. Salaries is almost always the most expensive item. They also have their rentals to pay. These are certainly very difficult times for private practice, but there is no question that we shall all, the human spirit is boundless, and we are certainly going to overcome this as well with, of course, all the assistance from everybody, including our patients and the government. Thank you very much, and thanks again for this opportunity of talking about this important subject.
Thank you so much, sir, again for that very detailed description of how OPD clinic has to be started in the private practice. There are a large number of questions, and again, there are a lot of people who are watching us on Facebook, YouTube, as well as on login pages. So we come to the last talk, and I would request Dr. Bharti to tell us about how to begin our OT practices post-lockdown. Ram Bharti needs no introduction at all. He's the past president of Delhi Ophthalmological Society and has a chain of hospitals in Delhi. Meanwhile, I think there is a question which is coming up, and after this presentation, we all can answer. When are the routine OPDs going to start?
Thank you, Dr. Namrata. I must thank Dr. Bhalla and Dr. Mahajan and Delhi Ophthalmological Society for giving me this opportunity to share my views on change in the OT practice in private sector. And these are, as Dr. Ashok said, these are very tough times for us, whichever way you look at it, whether you're working or not working. There are to be protocols followed for a situation where you have to come out successful, safe, without giving or getting infected. As of today, there's disruption by COVID-19 is OPD is 95 or more percent affected by for them who are working. Who are not working, who are very careful, probably it is 100% affected. And IPD is affected by more than 99%. So these days, these are very, very tough times for ophthalmologists or for the medical fraternity as a whole. Currently, what we are doing is only emergency OPD and emergency OT for our patients. So emergency OPD is limited to only the patients who are either follow-up or are coming with the conjunctivitis or trauma, or mostly retina patients. I had more than a couple of patients who had lost their vision in within 7 days or 3 days or so, and those are the patients which we're seeing more often than any routine patients. And as routine patients come in, if they can wait for another 15-20 days, we always send them back and ask them to come back at a later point in time when the lockdown is over and there's a huge risk of infection. That is why. So as soon as they enter, all cases are scanned with infrared thermometer at the entrance of the hospital. And if the fever is detected, which I would say anything around 99, they are not allowed to enter and sent to a COVID center, which has a facility for eye. Or if they want to go to the COVID center, majority of them would not, as COVID centers have a very, very scary kind of situation in the patient's mind. All the patients should be recognized and confirmed by their mobile numbers. That's very, very important. So what we normally do is they tell the mobile number, we call it. And if it rings, that means they are confirmed using the same mobile number. And we ask them to have Arogya Setu app loaded on their mobiles. So all our staff, all of us have Arogya Setu app loaded in our mobiles, and similarly all the patients who enter ought to have our Arogya Setu loaded in their mobile, and they will allow only one attendant, and both of them are recognized by their mobile numbers, so that we know that they have Arogya Setu and their mobile numbers are correct, and then only we let them enter in the center. Now for the OT, the recovery is long. It's actually going to be very, very long. So there's no routine OT for next 2 to 4 weeks. This is a very, very optimistic estimate. I am saying 2 to 4 weeks doesn't mean anything. 2 weeks is definitely not possible. 4 weeks is probably possible once the lockdown opens. It will increase gradually, and potential back to 50% is really, really long. Maybe 3/4. That's what I'm expecting, that in OT it will take at least 6 months or more to reach our 50%. People will be very skeptical about health and finance. Health is become the primary concern, and finance is the situation which is, because it's a byproduct of what is happening today. You don't get any finance. The impact is absolute. The financial impact is absolute. We are not, a majority of the patients who are coming are, in a very financially crunchy situation. The other important fact will be cataract and refractive will be pushed back, especially the premium surgeries for cataract like a multifocal or a toric or a femto flax. So they will be pushed back. And I think retina will be first to start. We already have done some retina surgeries already in our center. And that is the first thing to start because the retina cannot wait for 4 weeks or so. So with the enough sufficient precautions, we can, start the retina surgery, which we have already started. Now, as a protocol, all known or suspected COVID-19 positive patients requiring surgical intervention must be treated as positive. I'm talking about suspected, not really positive. So they should be treated as positive until proven otherwise in order to minimize infection spread. Allocating dedicated senior staff in key management role is crucial to minimize COVID-19 spread. So 2 points have to be noted, dedicated and senior. And I'll come to that in the next slide. And no GA patients, we are not taking any GA patients for the time being. We don't have that kind of facility as Professor Atul has. So GA, we will not be taking for some time because that can cause trouble and spread and aerosol production and so many things. Now, change to scrubs in the hospital as soon as they enter. And PPE for the staff at risk. And for this is for a general hospital, but for ophthalmology, everyone should be donning a gown, a cap and a mask, gloves, protective glasses, and shoe covers. This is a minimum protocol which everybody in the hospital should be following, and remove whatever is non-disposable into a 0.5% sodium hypochlorite and washed. This is we are doing every single day. Whatever is disposable is destroyed right there and sent for the incineration. Now, the PPE, necessary PPE will be the mask, normal facial mask in high-risk cases, FFP3 mask in high-risk cases, waterproof gowns, double gloves, protective goggles or visors, caps and shoe covers. This is a PPE for ophthalmology if you are dealing with really serious and nearly, very highly suspect patient. In the OT, the patient should be wearing a mask. Now, high positive pressure should have high air exchange rate. If it is possible to have a higher exchange rate, like more than 25 cycles per hour, you can use high positive pressure OTs. If that is not possible, then do not have any positive pressure in the OT and do not have any, because majority of us cannot have a negative pressure OT. We only have a possibility of a positive pressure OT in our centers. So if it is not possible to have a negative pressure OT or a very high exchange rate, please do not use a positive pressure OT at least at least 1 hour before and 20-30 or maybe later after 20 minutes after. There should be minimum equipment in the OT. So whatever is necessary, that only has to be coming in the OT. Not everything that you are used to. Remove whatever is not required in that particular case. Minimum movement of the staff. Nobody should be coming in or going out of the OT while the surgery is on. Majority of material used in the OT should be disposable, and all non-disposables should be kept in steel wire sterilizable basket. So don't put it back on the sheet or anywhere. As soon as you have a possibility, if the case finishes, use it in a steel wire sterilizable basket, which then goes into hypochlorite and goes into sterilization. The more important thing is these days there is a lot of fashion regarding keeping a bed, and that is very important, that operator or any staff with the bed should have mask with the adequate cover. Shouldn't be any exchange like what where when we don't have a bed, we can, snugly fitting mask is possible, and still more better will be to put tape, a sellotape, or a tape on the sides, so that there is no exchange of air. But where that important fact will remain, that the mask should be sufficient, snugly fitted, and there is no exchange of the air because of the bed and mask. Now, AIOS guideline, which have come recently, about a couple of days back, they begin with only daycare surgeries, only emergency surgeries, and all these surgeries, there has to be a chest X-ray done before taking them for surgeries. And what it is might not be possible to have a COVID, but chest X-ray is mandatory. They should be done during the routine hours, so that the team and facilities are at the best of their possibilities, and there has to be a complete team for any surgery. The more important fact which I mentioned earlier was that it has to be a very senior team, because of two very important and pertinent reasons, that it has to be a very quick surgery and a safe surgery. So senior consultants, senior surgeons should be doing the surgeries at this point in time, because we have to finish the surgery quickly and also successfully 100% times. All the precautions and with the minimum staff in OT are to be taken. Now, also there are multiple possibilities of doing a surgical procedure. So we have to choose the quickest possible surgical procedure for that particular ailment or the disease, and prefer topical anesthesia. General anesthesia is out, but even injectable or local anesthesia, if possible, should be avoided, and a topical anesthesia is preferred. PPE for all OT staff is preferable, and then during the surgery time, there is absolutely no problem for the OT staff to use PPE, because for the surgeon, it might be difficult. For the OT staff, it is possible. Now, as I said, if you don't have a quick exchange possibility, then no positive pressure in OT during and up to 20 minutes after. The other important fact will be to smoke evacuation from diathermy, because that is again an aerosol. Aerosol generating procedures such as intubation, extubation, electrocautery should be done with full PPE, and between the two surgeries, there has to be a gap of 20 minutes. That's very important. You cannot continue like you post 20 surgeries or 15 surgeries and are in a quick, succession. You are doing quickly all the surgeries. So that should not be there. You have to wait for 20 minutes at least between each surgery, so that there is no possibility of cross-infection, and also, if possible, the team has to change. If the team cannot change, they have to change the dress and equipment. Protocol-based disinfection of OT between two procedures and at the end. So all staff should remove clothes for disinfection. All staff should take a full soap bath once they reach home, and prophylactic HCQS 400 milligram BD on day 1 and 400 milligram BD OD for 7 weeks after that is one thing which will reduce the virus load if they are infected. So it is a prophylactic dose. They should be this should be taken with all the patients, with all the staff which are in contact with a suspect COVID patient. But if I mean, they have to be, the balance has to be between the possibility of infection and also possibility of complications because of HCQS. But protocol-based disinfection of OT is very important. The sodium hypochlorite mopping and the second case should be taken only after 20 minutes. Post-COVID, gradually elective procedures will start, and that gradual start is how long that will be is, I think we have to wait for the guidelines from the Delhi or All India Ophthalmological Society or the government as to when they want the elective procedures to start. And there is a lot of talk as to how many people are doing these surgeries, the routine surgeries and all, but I don't think it will be possible, because if something goes wrong and there is no protocol as of now, the SOP is not decided about the possibility of starting the elective procedures, then any surgeon who is starting the such procedure will have troublesome time later on. The COVID situation may last long in some form, and of course you cannot, as everyone is used to using a long list, you cannot start a long list immediately. It has to be a very, very slow progress. It has to be a very, very slow build up. You have to modify your protocols as per the prevailing situation, whether you can do one case or two cases or three cases in a day, or you can start one OT or two OTs, or all your OTs. It depends on what kind of situations are prevailing. Also, I must say that at this point in time, it will be also a possibility that you might not be getting as many patients initially. And when you're not getting the patients, you will have sufficient time to develop a protocol as to how many patients you want to do or how many OTs you want to start. And they all the cases has to be staggered. So we have to minimum number of OTs to start with, maybe one or maybe two. It has to be a long hours. So like instead of doing OT from 8 to 2 or 8 to 4, you can start doing OT from 8 to 8. So that if there are a number of cases and then you're using two teams, each for one OT at one point in time, for next batch, you can have another team which will do two OTs. So like maybe you will be able to do about 3 cases or so number of cases in one OT, and something like that, where two teams will be alternating and doing OT. So the number of cases in one OT will be small and hours will be very long, so that sufficient time gap is it. You're able to give a long time gap between two for the complete sterilization and mopping and everything, changing and sterilization of the sterilizable equipment. You should infected cases or GA cases or CAM cases, they can wait. All these cases have to be postponed. We may not do any DCRs. We may not do any other things for the time being, because that is not we want to, that is not the emergency unless there is a reason to do such cases. But especially the CAM surgeries, we have to postpone for a very long time, maybe a couple of quarters. Now, the most important thing for the OT will be counseling. It is very important. The patient as well as the attendant both have to be counseled about the possibility of surgery, about the possibility of recovery, about the time, about the conditions prevailing, and should be told, and consent should be taken for risk during special circumstances. and AIOS has come out with consent. So that consent is very important. And preferably, as I normally have been doing for a long time, and this is another special circumstances where even those who are not giving the consent earlier should have the consent, given the consent at least 12 hours before to the patient and to the attendant to read and sign, and preferably in their own language if that is possible. In their own hand they should write the consent and sign it and come with the signatures on the consent in the next morning. Now, instituting precise, well-established plan to perform undifferable surgical procedure and emergencies on COVID-19 positive patient is mandatory. So hospitals should prepare specific internal protocols or arrange adequate training of the involved personnel. This I am talking of all those possibilities where if you are dealing with the COVID patients. Here in ophthalmology, we might not be dealing with all these, but there has to be a protocol, made for all these situations where we are dealing with COVID patients, and that has to be very, very strict and stringent and to be followed in total. It is important that all the non-COVID patients are protected, and the protocol should be very strict on that. Separate pathways must exist to keep suspected or infected patients away from non-COVID infected patients or non-COVID patients. So entry and exit should be separate in all the hospitals, and they cannot be using the same pathways like an elevator where all the patients will go up in the same elevator and down in the same elevator. So this is very, very important that all the patients going up will not be coming down from the same elevator or same path. And in all the patients, there has to be masks. Very, very important fact is mask, or if you do not have a 3-ply mask, you can use double 2-ply mask over all these patients so that the aerosol is not there. The OT will be dictated by health officials. It will be for emergent and urgent cases, only site-threatening cases, with the utmost protection of staff and patients. It has to be a very quick surgery and a safe surgery, and all senior surgeons will be doing this surgery, unlike in bigger institutions where the second line of surgeons are doing, because second or third line of surgeons are performing the surgery because they have to also learn, have practice, everything. But leaving that point at this point in time, and the senior surgeons should be involved in doing all the surgeries, and it will also be governed by the state and the country policy so that we can start the surgery accordingly. And I'm not saying anything which is going to start very quickly for the routine procedures. Thank you very much.
Very good, Doctor.
Thank you,
Hello.
sir. Again, that illuminating talk on how to manage operation theatre in the COVID and the post-COVID era. And there are a lot of questions which we will be taking one by one. And I think first question is for Chief RP Center, Professor Atul Kumar sir, and people want to know that how do you think and when do you think the OPD or the OT should be started, and particularly in OT, which are the surgeries which will be taken up first?
See, the AIIMS is already having a backlog of routine non-COVID patients. We should not, in our over obsession of COVID, we should not forget there are other diseases of the eye and other diseases of the body which can be life-threatening and eye-threatening. So we have to pick up in ophthalmic center patients who are not, who are basically having other retinal problems or other cornea problems or other contact problems or orbit or whatever. So I think in a week or 10 days we'll have to start. In AIIMS, the director has declared that within a week we'll be starting non-essential or elective surgeries because we have a huge backlog. We'll be starting elective surgeries in a week or so as per what the director has told us. So we are preparing very fast our SOPs, guidelines, so that we know what to do in the OT and what to do in the OPD. But OT, this will essentially remain the same. We just ask the patient to wear a mask. We'll wear a mask, of course, which we're already wearing. And we're going to get COVID testing for all patients who are going to be admitted for surgery because Government of India, Ministry of Health has declared that all patients who undergo surgery have to get COVID testing done, RT-PCR.
Thanks for that clarification, Dr. Atul. I think that was a long overdue clarification because there had been a confusion on that.
Yes.
I think the government has become very clear on that now.
Yes, very clear now. Sir.
Yeah.
Now the institutions will be following that.
We'll have to get it done.
Yeah. Because otherwise disrupt your services, which
Won't
can
disrupt
otherwise
us.
be very
So
bad.
once you know is cabinet COVID negative, then you can go ahead with the routine precautions.
Sir,
That's
another
very
thing-
encouraging, sir. That's very encouraging. I
Yes.
think I should thank all the speakers and all the known personalities of ophthalmology for this DOS webinar today, for their presence and giving a very good idea. This is very encouraging thing, sir. You are starting the OTs because in private sector we are afraid because we have got little resources to do the things.
So the
And,
director has announced for next week, sir.
And
1 week.
mostly we people are depending slightly on volumes also because if we do 2 surgeries, 3 surgeries, then even the cost we are not able to recover because the cost has already increased.
Yes, I understand.
So that's a
So
good
the-
thing, sir.
That'd
Yes.
be good.
So, Professor Ritu, ma'am, what is your? I know that in GNEC you will not be able to start immediately.
Yeah, we are actually planning because right now our center was earlier taken as a quarantine center, but then at the last moment we didn't get any patients because the guidelines changed. So we are planning and I'm working on all the SOPs. So maybe in another 3 to 4 weeks time, we're planning to start the elective surgery. I mean, I'm planning first the emergencies, go in a graded fashion. I don't want to go all in one go. Go in a graded fashion, see the degree of emergency in every case and see how things go and then start with it. And again, I would like to say about the air conditioning in the operation theatre. Because we don't have to use the AHUs with positive pressure. There has to be a negative pressure OT. So I'm already in talks with the air conditioning people to make the changes in the central AHU. So that we can create the reason, and there should not be any recirculation of the air. So the PWD people have told me they'll take another 3 weeks to get my OT to that level, and hopefully in 3 to 4 weeks we should be at it.
Thanks, Subodh.
There's one very interesting question. What, like we said, is that pre-operative examination, and now according to government guidelines, is a must for patients undergoing surgery. Because, our ophthalmologist friend has asked, suppose the patient develops positive PCR test after the surgery, and asked whether the surgeons who operated on him had the test on themselves. What do you say on that, sir? It's a hypothetical, but it's a valid question, sir.
You mean the test was what? The voice broke in between the.
Yeah.
We want to say it's a COVID positive patient and as
The
a emergency
surgeon-
you have to operate.
No, the
Positive
patients.
post-op.
Yeah. No, sir.
Yeah, the
Patients are
patient-
nowadays asking that you are asking us whether we are COVID positive or not. So the patient may ask whether the surgeon has got his test done or not,
Yes, he's
and
right.
he is COVID negative or not. So that is the thing.
So only
I
thing
What do you
is,
say on? What do the
I
panelists say on
we have
that?
to be very gentle when we break this that we have to get the COVID test and all, because the patient may ask you also the same thing because he's going to get himself operated from you. So maybe we should tell them that we are not having any symptoms or anything which suggests that you've not been in a containment area. But I don't think we should get the COVID test done until and otherwise we have some symptoms or fever or something to suggest we are having URDI. So
And
if we are-
how frequently can you get it done? You're going to operate every day.
It's not possible, sir, because that means we'll have to get it done every week.
every week. So I don't
Every
think it's
week
feasible.
surgeon will have
not
to get it
practical.
done, and we don't
Not
have
a
that
practical.
many kits and facilities. We'll be wasting those kits and facilities on this operating team, on the
You have to,
health workers.
The
you
other
will tell him you're
aspect,
taking full precautions for
the
yourself.
other aspect, Dr. Atul, is that since we know that RT-PCR has 30% false negative,
Yes.
and they may turn out to be positive later, which would then entail disruption of the hospital services.
Yes. Yes.
So, would it not be advisable, if economically viable, to have a PPE for all surgeons? At least that is true for all those procedures which are aerosol generating, such as oculoplastic procedures, such as procedures, endonasal procedures, and of course orthopedic procedures, cardiac procedures,
Definitely.
and so on, where you are using drills or where you're using cauteries, and so those may it may be necessary to use PPEs, full PPEs in those.
So I totally agree with the N95 as a PP, and you can have those waterproof gowns. But I don't think the Tyvek suit which the COVID area they wear, it's very suffocating. You can't breathe. You can't even go to the. I mean, you can't do anything. It's very difficult to operate also. Maybe we can have these waterproof suits for ourselves, for especially as you mentioned, the nasopharyngeal area, DCR and all, those areas are very prone to have aerosol infection. So those areas, probably an N95 face shield will be very important, and we wear a waterproof suit, sir.
Maybe if we have an apron, maybe an apron over a routine gown, which is right, which is waterproof, that should work.
Dr. Ritu, the question arises that some of those may not be sterile, those PPEs
Right.
that are available. So you
Right.
need to wear a sterile gown, a disposable
of
sterile
that.
gown on top of a plastic PPE, which is going to make it even more suffocating.
Yeah.
Plastic shield would be required, sir.
There is one
For the
question
face.
to Dr. Ritu, that HEPA filter does not work without positive pressure ventilation, and we are advocating negative pressure ventilation. So what are the changes we require? And second question is, can we do with a lot of single surgeon OTs have split ACs? What about those? Can split ACs be
Yeah,
used?
yeah. We've been really debating about it, and I am talking to all the air conditioning engineers about that. Now, as per the our earlier criteria, it was that we should not be working with window AC, we should not be working with split AC. I mean, that was important for us from the endophthalmitis point of view. Now, with all these changes coming, what we worked out today with what my engineers suggested, I mean, it has to be worked upon that when the positive pressure air is coming into your OT, and once it is taken out, like it is getting exhaust is happening over there, so there they are planning to put another HEPA filter, and whole of the air is actually going to go out. It is not going to be recirculated into your system. And the air, which is the fresh air, which they are planning to circulate in again. As a result of that, though now the temperature is going to be quite different. So when you're getting that heat coming in, so that fresh air comes in and then it goes to the AHU, no recirculation happening. So for that, they suggested that they are going to make certain changes so that we can work it at that level. And plus, along with it, they suggested that we should have the split ACs working so that we can maintain the temperature between 22 to 25 degrees centigrade. So this is what the air conditioning people have suggested, that the air which is going to be taken out is not going to be recirculated into the system. It has to be completely exhausted out. So that's the way they're going to work.
The two basic questions. One, while doing refraction, what do? Do you sanitize your trial frame and the trial lenses every time after every patient? If so, how do you do? Hypochlorite? Do you use sterilize this thing sterilium, or you use soap water to clean? If so, the number of refractions will come down. And second is, the ophthalmologists get a lot of referral from ICUs and emergencies for fundus examination. So cautions required, and most of them are using direct ophthalmoscopes at that time.
एक तो Dr. Bhalla, direct ophthalmoscopes will have to be out, sent to the museum.
Yeah.
Ophthalmoscopy should not be done now with the presence of COVID-19 and SARS-CoV-2, right, coming from a respiratory tract. somebody sneezes on your face at 6 inches, 4 inches distance,
Yeah, it's dangerous.
fundoscope should not be.
It's very dangerous. I agree.
They use an indirect ophthalmoscope or fundoscopy, or you use the 90D through the screen, through the plastic or the X-ray screen, as we are doing. We're using the X-ray screen here. So what you can do, I tried doing it last 5 to 7 days. I mean, see cases directly through the screen, and you can easily put the 90D and see everything. It's no problem at all. Everything of the retina is visible. So anterior segment, I'm sure, is also visible. So what I'm trying to say is that we should not use direct ophthalmoscopes. Indirects are there, 90Ds are there, slit lamps can be there. All these surfaces have to be, we can clean it. We can clean all the slit lamps with a alcohol-based rub like Sterilium. Very useful. The Sterilium can clean everything. Even the surfaces of the slit lamp can be cleaned with Sterilium. Or you can use Bacillocin. Bacillol. Bacillol can be used after every 1 or 2 hours. Bacillol is effective in the OT as well as in the OPD.
Dr. Atul, the one thing that I'm going to miss if the direct ophthalmoscope goes to the museum is the immensely useful distant direct ophthalmoscopy. I think that gives you so much of an evaluation in one glance.
Yes, sir.
That is
distant direct, yes.
And as for the refraction, what we're doing is we're doing the very minimum or minimum essential refractions. We are using gloves which are changed after each case. The trial lenses that are handled are also clean, and they are kept to the minimum possible. Trial frames are all cleaned after every case, definitely. So
I think the guideline is this only, that defer refraction. If you can defer it, and just take it up. Yeah, just take it up if you must do it.
Generally, an auto ref followed by subjective with minimum possible lenses.
So, what about the asymptomatic COVID positive patients? That's a major thing. Asymptomatic COVID patient, positive patient.
Once he's COVID positive, whether he's asymptomatic or symptomatic, so we'll have to maintain the safeguards in the OT and OPD. All the safeguards we'll have to maintain. Because transmissibility will be high, sir. He may be asymptomatic, but the person who gets it from him, maybe the surgeon or the physician or the ophthalmologist gets it from him, may become symptomatic.
So nowadays, what we are seeing, the asymptomatic patients which are coming with the COVID positive results, and they are not knowing it even they are having the COVID. That's a major problem we are facing. And
so we'll have to wear full PPE, sir. Yeah, except for the tie-back suits. Probably we'll have to wear waterproof gowns, head cap. We'll wear a mask. N95. We'll wear goggles, transparent goggles, or something. We'll have gloves and shoe covers, sir, right till the knee joint. You have to wear everything, sir.
Hey, Dr. Mahajan, I just want to ask that you had those asymptomatic patients, and how was the COVID testing done? I mean, is it the routine?
No. Mostly the testing is done by the other people. They say they are asymptomatic and they don't have any symptoms. They are still cooperative. They are not come to us.
Why was the test done? Because in asymptomatic patients,
because they have come in contact with someone. That's what in the news and every year. It's a COVID positive patient, but asymptomatic.
So contact of a COVID positive can get a test done.
So you're talking about contact of the COVID.
Contact.
Yeah, asymptomatic contacts of positive patients.
Yeah.
So also that once, how long do you wait? Like pre-op patient has come, you do the testing, RT-PCR testing done, and you wait till the result comes?
Yes, 6 hours. 6 hours the RT-PCR result by evening. You take the blood at 1, it's there with you by 7.
And if it turns out to be positive, is it mandatory for ophthalmologists to report this because it's a notifiable disease?
It is. There is a form by ICMR which is automatically goes to ICMR. All the labs are supposed to fill up a form which is an ICMR approved form with heading as ICMR, and the form goes there, and the lab has to immediately inform the ICMR.
So it is not mandatory for ophthalmologists to report, sir?
No.
I can do
it. The lab and the form will serve the purpose.
Yeah.
Form is, I think, uploaded, scanned and sent by email also to the ICMR authorities.
Dr.
There's
Ritu,
there's another question, sir, which is specifically related to retina, and that is what precautions, because there are a lot of people who are giving intravitreal injections because of the reason, because of the fact that patients may go blind. So, what precautions should be taken while giving intravitreal injections?
The first thing is giving injections is a sight-saving procedure. It has to be done as an emergency, mostly for wet AMD, neovascular AMD patients.
Yes.
Even DME patients get their vision dropped so badly, just waiting, that nothing will be achieved by waiting, and will in fact cause a macular degeneration, cystoid macular degeneration. So we have to do the injection. Second, what we do is in the minor OT, we maintain distancing in the tables. Third, we wear proper N95 mask. We wear a cap. We wear gowns, and we wear gloves. The patient's eye is cleaned with betadine, and we put a airtight offside covering the lashes, and we take a disposable 30 cc syringe. And the injections are usually which we give are single dose, and the ones we inject, the patient give the patient antibody drops. I don't think we do anything more than that. So we changed only that we wear N95, patient wears a mask, which he was not wearing. Otherwise, our OTs are the same. We have a UV light also over there in the minor OT. This UV light in the night is of great use. It should not be switched on the day. The UV light kills all microbes, spores, everything, including virus. And the instruments and the equipment in the room also, we use switch on the UV light for 12 hours, 8 to 8 or 7 to 7 in our RP center. So this UV light is of great help in the night. Why we don't use it in the days? It is known to cause skin-borne like keratosis and elastosis, premature aging, and all that stuff is known to occur with UV light. But UV light is a great sterilizer, so it can be used in the night. So in the minor OT where we give the injection, we use besides fogging with, so we use in our center we use hydrogen peroxide. Hydrogen peroxide 11% is as effective as 1% sodium hypochlorite. So we use hydrogen peroxide. We use hydrogen peroxide.
So
We don't use bleach.
UV light is again, it's very important. We also use it for 12 hours in the night or more than 12 hours in fact. But the other thing is, if it is on during the surgical process, sometimes also causes SPKs. It becomes, eye becomes very pain. Even if the light is not falling on the eye and is scattered all over the OT, there's still a possibility that you get SPKs and have a lot of red and watering eyes. So
and the patient, surgeon's skin will get affected.
Yeah.
So it should be switched only during the night, sir.
Yes, at night.
I think that's clarified very well that it is only during the night that it is switched on.
Yes.
So what about hydroxychloroquine prophylaxis? This question always comes up.
A very controversial question, but I feel only patients who are working in COVID isolation areas or in COVID wards, like at Jhajjar or some, for naming for AIM's sake, that we are having very mild symptomatic patients admitted in Jhajjar AIMS. The serious patients, we have only 7 in the whole of AIMS. Only 7 serious patients. They are in ICU at trauma center. Only those areas, those chloroquine should be advocated, and that's what world over. Even the Americans, I don't know about Americans, but mostly they're feeling it can only for those patients. Routine like us ophthalmologists may not use it. There is a recent report by American Academy of Ophthalmology yesterday, which was reading that bullseye maculopathy due to acute toxicity of chloroquine can occur in patients taking short doses of chloroquine because of COVID disease. So they have not proven it. They have not proven it. They said we are undergoing a trial. So, but even then, some people are taking chloroquine is no harm, but it should be hydroxychloroquine. Chloroquine is more toxic than hydroxy. So hydroxy is less toxic. Hydroxychloroquine can be taken by people who feel they are at risk. But there is no RCT to guide us. Right?
Yeah, she is the right person to.
Sir, there's also a request that if the way the face shield is made, like we make in RP center, and the way it is done, if that video can be given to all.
We would definitely like to share it with everybody, so that everybody can make it.
That they can.
Yes, we'll ask Professor Velupandian to make a video clip. We'll give it to you, Namrata, and you share it with Boston. Yeah.
Thank you so much.
There are some question for government setup for Dr. Ritu and Dr. Atul. How do you foresee there will be a surge of patients once the lockdown is over? How do we advise request the government to frame some guidelines for the government setup so that number of patients or number of hours is restricted? Because that is going to be a huge problem, maintaining social distancing and everything is going to be a big problem in government setup.
You best is that you stagger.
Yes, sir.
Call patients from 8 to 10, maybe 20 patients. You see it until 10, then call again 20 patients, between 10 and 11, and then again call 10 patients, 10, 20. So this way you can see about 50 patients a day.
Some sort
Before
of
lunch.
where they can take appointment beforehand.
Appointment
Those
also when you
patients who
stagger
take
the appointments.
appointment are allowed to enter.
They should not
It might be
come
difficult
at
then.
all at the same time at 10:30 or 9 to meet you, because they all want your opinion, so they should stagger themselves. So you'll have to sit, you'll have to work more.
And how do we write the prescription? Because they are going to come with even the new prescription slip will be given to them and they are going to hold it. It was, I saw in one of the videos where a paper is taken by the doctor to write the prescription, because here they'll be handling all the papers.
So
Either
I
we
think you wear
depute
gloves,
somebody to write.
and you can clean, wash your gloves with sterilium and rub. After every, you can wear gloves because there's no harm in wearing gloves. In many countries there are wearing gloves, and once you wear gloves when you're seeing patients, also you make sure that you clean your sterilium with some cleaning solution, alcohol based.
I think I agree with
It's
it.
well
because-
recommended that gowns and the gloves can all be cleaned with sterilium, and after seeing 7-8 cases, you can take off the glove and throw it in a fresh glove.
See, capping is not going to work. Whatever you may tell the government, they are not going to cap it. I mean, that's a real situation. The only way in your hand is to stagger the patients. So maybe your OPD timings may be different. You might have to start early. You might have to start at 8 o'clock.
Yes. You'll have to increase the seeing timings.
Sir, it's going to be a very big task for you, because your OPD that both at RPC and GNC is always flooded with the patient. They are lining and lining and lining.
We'll give
I don't know how we
appointment.
control it.
OPD will give by appointment.
Maybe
And
next level
examination with face shield is very difficult while both working on slit lamp and with operating microscope.
Yes, it is.
Otherwise, what do you do? Remove the face shield
See,
and
I think face shield in the OT will not be required,
will not be. On slit lamp, sir?
because you have the patient is masked, you are masked, he has been tested, and you've got gowns and drapes over the patient well, and you're sitting over the microscope, and there's no chance of direct aerosol. But only in OPD there will be a problem. There is a problem, and but that's the best way to probably see the patient if you can through the eyepiece. If you have a problem, then probably you have to take it off, see the patient, and put it on again. I don't see any other way, because face shield is the only other way. Besides face shield, the option is transparent goggles.
Yes. I think what we have been doing is using the goggles in the operation theater and using the face shield in the OPD. That is the routine that we are following.
goggles have to be
So
tight goggles.
here I
Yeah,
want
they
to
have
mention
hugging,
one thing.
Hugging goggles. Yeah.
Yeah. One thing I want to mention here is, if you're having a shield between yourself and the patient on the slit lamp, that works fine, because still you can look through the eyepiece. But
Yes,
if you're wearing a face shield, I was looking through a face shield in the slit lamp on a patient, and I was suspecting there's some corneal haze, and it was the haze which was due to the face shield. So even face shield while working on the slit lamp is, slightly dicey, and I'm not sure what kind of transparency you were getting with the face shield.
You'll learn to interpret it through that translucency.
Sorry?
You will learn to interpret it through that translucency.
Yeah. After some time you will, but otherwise it's a big, large shield. A flat shield is better. It is available for something like 300 rupees from some manufacturer, which we got at a large plastic, which is, your optics are away from, there's a hole for them.
Okay, one more question to Dr. Grover and Dr. Bharti. As Dr. Atul said, they are going to start with a routine OT, and that routine OT will have cataract also. When you are planning to start the cataract, sir? Both of you, because you are type practice.
Okay, I'll answer it first. First is, when we get the patients, because I don't know how many patients will come to a private center for getting their cataract done. Even if they are booked, like for the patients who were booked during when the lockdown started, they're only calling and asking us when will they be going to start. So at least 4 weeks, or when the proper guidelines are there from AIUS or DOS.
Or
And I think
from RP Center, or from RP. When RP Center
RP
starts,
Center is a benchmark.
I think when RP Center starts, then everybody will have the confidence to start.
Yeah, but they are benchmark. We have to follow. They are themselves a guideline, but we are not, having unless we have a proper guideline from some society. I think we cannot start. But it will at least be 4 weeks.
I think this is well answered. You answered it well. The guidelines are needed because to protect yourself, because there are guidelines and you can follow it. Dr. Grover, sir?
Dr. Namrata, there
Yes,
will
sir.
be a little delay. We have to have clear-cut guidelines from the government first of all. Once we get that clearance, and
Yes,
by
sir.
that time the protocols are well set, which Dr. Atul will do for us.
I know.
Then we can go ahead.
I think already sir is at the SOPs, already formulating the SOPs for RP Center. And I'm sure when that is what I said, like all the other webinars, which, are so disappointing because, people get depressed after listening to the webinars. This is a very hopeful webinar that way, because I'm sure when RP Center starts, it will give confidence to everyone else to start their surgeries and their OPDs, elective OPDs. And I'm sure
That's why
sir is
we
going to
need
advise the government accordingly.
Yeah. It's a Professor Atul gave a very short time, and Dr. Ritu also gave within 3 to 4 weeks. That's very encouraging. We are thinking in months and months.
Yeah.
That's major thing.
No.
There's one question I want to ask.
Start in a week, 10 days.
I want to ask Professor Ritu Arora, because cataract is going to be the most common surgery which is performed, ma'am. People are asking, what would you do with the tubings, with the cassette, with the phaco probe, with the phaco needle? How would you sterilize? Can you just, because is phaco aerosol generating procedure? I think that myth has to be clarified.
I mean, my knowledge goes, phaco is not an aerosol generating procedure.
And what would you suggest for the surgery?
So what I would suggest is that maybe in between the procedures, obviously, I mean, one can change we do change the tips always. And the handpiece could be, just rubbed with the sterilium. Handpiece to be rubbed with the sterilium. And cassettes, I guess one has to continue, I mean, it would be too expensive to change the cassette after every case.
Tubings, ma'am.
Tubings will stay the same because your handpiece is staying the same.
Practice में लोग मर जाएंगे.
Handpiece will stay the same. I mean, one can maximum clean them with sterility. That's all. That's why I look at it. Only tips are going to be changed.
Sir, there's another question for you, Dr. Atul sir. Do you recommend complete blood count before all surgeries and X-ray test before all surgeries?
Any even without any reason for it, I mean without symptoms?
Without symptoms.
No, we don't get a blood count or a X-ray test. No way. If he's a diabetic, we get diabetic clearances from the endocrinologist, if required nephrologist. If he's a cardiac patient, we get clearances from the cardiologist. But usually they don't need a blood counts and all this.
Are you planning?
Maybe people require X-ray test.
What about hepatitis B, C, and HIV?
The same protocols of PPE, the same as for
would you
COVID.
test them in all cases?
Yes, sir, definitely. That we would.
Any special precaution? There's one question coming. The surgeon is above 60 and is also having diabetes. Should he be operating?
I think there is no.
Because he comes according to government guidelines, he comes in a high risk category.
So you want to finish off all the senior surgeons? They are over 60. I am over 65. So you think our days are over?
This is question from the audience too.
No, I think not, because as it was rightly pointed out, the surgeries have to be done by senior people because they have to finish fast. So if all you ask 60+ surgeons to go away, then you have a chunk of junior people doing it, which is not advisable.
Rightly said. I think that settles the issue, sir.
Yeah. So I think we've had a great webinar. You want to ask some more questions?
Some more questions.
Okay. Then make it like a rapid fire round quickly on one-liners.
single surgeon OT with the OPD and OPD with no windows. Do you need to make some changes, because a lot of them have now just AC and it's a closed chamber, no windows.
Definitely.
Keep
windows.
all doors open. Keep all doors open.
And fans on the walls. Those small fans on the walls can be installed everywhere.
And exhaust fan can be installed.
Yes.
And how easy or difficult it is to operate with PPE on?
Cannot operate with the PPE on.
The classic TVAC PPE, absolutely difficult, very impossible, as Professor Bharti said.
Dr. Bharti, what will you do if there is a patient who is positive for COVID-19 and he has to have an emergency surgery?
Refer to
Send to Gangaram.
refer to some other hospital.
Sir, with temperature rising and AC not in the OT, I don't know how it's going to be.
It's going to be tough. It's
The
not
AC in the AC will.
We'll have to work out something in the AC.
Yeah.
They all have the positive pressure ones with HEPA filters. I'm going to sit down, do some brainstorming like Dr. Ritu and talk to Dr. Ritu as well and work out some modification. You can't do the operation theater.
Yeah, but my engineers really suggested something very, very nice, you know.
I'll share
They
my
said they're going to work on it.
I'll share my experience while we were residents in 1979-80. We used to ask 10 patients to bring a big silly of barf. आइस का सिल्ली लेके आओ, 10 पेशेंट मिलके एक लाते थे, ओटी में हम रख देते थे उसको, and then we will have a little bit of cooler, atmosphere in the OT because no outside air was, being used. So fans and ice, large chunks of ice, a couple of them or 2 or 3 of them, though there was a water flowing on the floor on one side, but the AC, the OT became a little cooler. So this is what we used to do our residency days. I'm talking.
Dr. Bharti, you are no longer 25 also. That is.
Okay, I think with this we will conclude the webinar. We had great inputs.
One last
great
question.
Insights. Okay, one last question.
Is it advisable for the private people in the private sector to increase their charges to accommodate for all these extra things, PP, mask, and other paraphernalia which they will be required to use?
Dr. Bhalla, there will have to be a balance between 2 factors. We do know that the paying capacity of people will come down. But at the same time, we are going to add significant costs to it. So you'll have to see according to your practice whether you have a population which can afford that extra charge for the extra spend that you're going to do. If you have, then you should, because as it is, what I was talking about was balancing your budget is not all that easy in the private sector. In these days, the volumes will come down.
But I think it is more important to protect yourself, and so
Yeah, right. Now, one last question.
You should do it.
One should not cut down on these things because
you would
you
not
are
compromise on
yourself.
this in any case. Question is whether you'll pass it on to the patient or not.
exactly.
So many of these things can be reused, like those N95. As per the AIMS guidelines, can be SOP. You can use it 4 times on mask.
So we'll have to work out.
Are you asking for the COVID test for every patient who are going to undergo surgery, sir?
Yes. Yes.
Okay.
So thank you so much. I think any more
Thank you,
questions,
sir. Thank
Dr.
you.
Bhalla, sir?
Yeah.
Can we conclude?
I think,
Okay. Thank you very much.
Wonderful.
Yes, madam. Continue, please.
I would request
Thank you
Dr.
so
Bhalla
much.
to give a vote of thanks, please. It was a great webinar, I think. So
think
many
it was.
queries which people had in their minds have been solved by all the 3 people who spoke and Professor Ritu Arora. We are really thankful to you for that. Dr.
think
Bhalla,
it-
vote of
And
thanks.
all other panelists.
It was one of the best
So,
webinars because
all the
this
other panelists.
webinar has generated really a lot of hope. Now, because we named the webinar post-COVID area, that means we are already thinking of having passed the difficult times. And
Yes.
I'm really thankful and grateful to Dr. Atul sir for sparing the time and clearing so many doubts and coming with the guideline that pre-operative testing, I think that will give a lot of nerves that surgery is possible if pre-op testing is done. And Dr. Ritu Arora, also I'm really thankful. Madam was very busy with the COVID patients in our testing facility. Dr. Kaur sir, thankful as always, who's been my teacher. And again, I taken back to those times where he taught us once again with the same old charm. Dr. Bharti sir, who has always been very helpful, and when I requested him to join and give us wonderful tips, he was so kind enough. Mahajan sir, who has been very encouraging, and Dr. Namrata for conducting the whole webinar so nicely and beautifully. I think really wonderful, ma'am.
Thank you, Dr. Bhalla sir, for
Thank you, Dr. Bhalla.
organizing the whole thing. You were the man behind the.
Yeah, Dr. Namrata and Dr. Bhalla really did a nice job today. Thanks.
Well,
And
thank
last
you,
but
sir.
not the
Thank
least,
you, sir.
we
Thank
are
you so
thankful
much,
to
sir.
Antod people.
Everyone.
You involved Professor Atul, that's very good thing.
And Raman
He
for
is very hard to
putting
get,
up with all our idiosyncrasies. We got the things changed so many times, and he was so very nice. Without battling an eyelid, he did everything, sir. Once again, thank you for
Thank you, Raman.
everyone, sir.
Thank you, everyone. Thank you, DOS.
Thank you.
Thank you, sir. Thank you for being there, sir.
ठीक हो गया अच्छा हो गया
बढ़िया, sir. Thank you so much, sir.
अरे
Thank you.
मैं बोल गया
So, how was it, Raman?
Yeah, it was very good, sir. This is nice. So we will get the data immediately now.
Yeah.
That we will put it in the group. Sir. So online on the as the others like Facebook and the WhatsApp, we got a good number of it.
And give
Almost around.
Facebook also, I'll post it there on the Facebook page of DOS. We can, and I'll post on myself also the recording of the whole.
Yes. Yeah, recording will remain the.
Yeah.